Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Ian. How you doing, Ian?
Good. Thanks for having me come on board.
Well, I really appreciate it. It's been a hot minute since you were on last.
Yeah, and you get the new soundtrack and the new video appearance, which is even better.
Oh yeah, like we're definitely high speed right now. But if you wouldn't mind, would you mind doing just a real quick introduction of yourself?
Yes, I'm Ian Wedmore, an emergency physician. I ran the Army's Wilderness Fellowship. I ran the Army's Diploma in Mountain Medicine program, and I'm still running the Diploma in Mountain Medicine program for DoD-affiliated entities. Still working at Madigan. I was in SOCOM with the JMU for 18 years during my military career. And I've stayed involved in teaching wilderness medicine, emergency medicine, prolonged field care, and tactical care. And just as a disclaimer, I'm still the immediate past president of the Wilderness Medical Society, so anything I say about them needs to be taken with a grain of salt, apparently.
Yeah, of course.
Yeah.
But that also makes you the perfect guy to talk to, because I would like to go over the new high-altitude CPG in the joint trauma system. And since you're number one on the page, I thought you'd be the perfect guy.
Yeah, thanks. I'm really excited that this CPG came out. There's a lot of work that went into it. I mean, you look at the authors. We've got a whole host of experts on there in all different aspects of going to altitude. This started a couple of years ago when Colonel Missy Gibbons reached out to me to work on one. But then at the same time, Wayne Popowski, who's really the heavy lifter on the CPG and really the one that brought it all together, asked me to work on one. And we brought both of those together to come up with this product. Excellent authors on there. Got to give one more shout out to Matt Welder, because he was really the one that pulled this over the final finish line to get it done. And not to leave out all the other authors, they all were significant contributors. I just can't name everybody in this short period of time. But excited that we actually have now some altitude CPGs that go beyond the scope of the wilderness or civilian-sided ones. There's obviously great approaches to altitude medicine out there. Wilderness Medical Society has probably the most well-known CPG for it. And this actually takes us, it's based a lot on the WMS, which are excellent guidelines, but takes it a step beyond for the military austere provider that's going to be in a different situation. No-fail mission, have to go there, have to suddenly ascend without acclimatization, likely getting stuck much more commonly. So hope to cover all of those areas that providers may come across when they go through this.
Very good. Perfect. So let's start kicking this off. If you wouldn't mind, base level, we have acute mountain sickness. So I guess what's kind of the pathophysiology around that?
So there's a number of pieces of pathophysiology behind it, but really what it comes down to is that you've ascended quicker than you've allowed your body time to acclimatize to the physiologic stress of altitude. So that's probably the easiest way of explaining it. It's just you haven't given your body time to adjust the normal adaptations to altitude, which we know are increased respiration, increased excretion of bicarbonate, some metabolic changes, some erythropoietic changes, a whole host of things. But really, you're not giving yourself enough time to adapt. And that leads to the symptomatology, leaky blood vessels, which leads to the high-altitude cerebral edema and high-altitude pulmonary edema. Now, I think what's great about this CPG is the Joint Trauma System did an excellent job with the graphics and the tables of this to make it very easy to flow through and very easy to understand. Even early on here, you can see the criteria for diagnosing AMS, which is going to be the most common and milder form of altitude illness, acute mountain sickness, and then the diagnostic criteria for high-altitude cerebral edema and high-altitude pulmonary edema, which are the much more serious ones. And then it goes through a nice stepwise process of both treatment and then what to do if you can't bring somebody down, which we know is the definitive answer for altitude sickness. And obviously, we're going to be in situations, or the provider's going to be situations where that just may not be doable for a whole host of reasons. So this goes beyond the civilian guidelines and kind of giving a stepwise approach to, okay, you've done this, then what's your next step? What's the next thing to give? And to continue that until you can either eventually get somebody down, or if this goes on long enough, maybe they'll have recovered, hopefully.
Mm-hmm. Yeah. So if you wouldn't mind, let's walk through some of those symptoms. So, whenever I'm reading, an altitude illness, CPG or an article or things like that, I think of myself, in 2003, 2004, private or specialist humping those mountains. And I feel like I've had pretty much all of those things, headaches and feeling fatigued and things like that, confused, which was generally like a life state. But, how do I know that this is the beginnings of mountain sickness, for example, versus, he's just dehydrated, or, he's not in good enough shape to be where he's at?
Yeah, and you're exactly right. I mean, there's definitely some overlaps in a number of those conditions, particularly when you're in the mountains. And when you go through the flow sheet here, it talks about the diagnostic criteria. But I think in particular, if you go through the criteria and then use the scoring system, so the higher your score is on the Lake Louise mountain score, so that's a basically internationally accepted standard for how to score mountain sickness. The higher your score on that, the much more likely it's going to be for altitude sickness. Now, a couple caveats, obviously need to be at altitude to get altitude sickness. And we typically say that's going to be 2,000 meters or higher in elevation. Can happen as low as 1,500 meters, but if it's below 1,500 meters and probably below 2,000 meters, it's probably something else, right? So that's going to be your dehydration, your exhaustion, or whatever else. Then you have to have the headache. So if you have a whole bunch of other symptoms without much of a headache, it's not going to be AMS.
Mm-hmm.
Then after that, you have to have the headache and one of these other things. And if you go down to the end of the CPG, there's a flow chart that gives you a scoring of all these things. And the higher the score is, not only the more likely it is, but the more severe the AMS is. Now, I will grant you, there is some overlap with that, right? If you're really dehydrated and completely out of shape, then you meet the criteria for AMS, right? You're going to have a headache and you're going to be really fatigued. So you're going to have to use a little bit of clinical judgment also to kind of parse out that little bit of overlap in this.
Okay. No, I think also a lot of these criteria kind of assume that you've stopped movement, how long of a stop? Because I imagine, you're on patrol. Somebody starts complaining of a headache. Usually tell them to shut up. Then they complain again, 10, 15 minutes later. Maybe we now take a quick halt. How long do you have to stop before you can say, like, his heart rate has not come down, his respiratory rate has not come down, and this would be out of normal for somebody that would be doing this kind of operation?
Well, you bring up a couple of really good points there. One, there's very little as far as vital signs or physical exam findings that goes into the diagnosis of AMS. In fact, there's none. It's all symptom based.
Mm-hmm.
So I think the reality of that, what you could do is, you'd stop, you take your 10-minute rest, you have somebody drink some water, and then you see how their symptoms do. If it's AMS, it's not going to get particularly better with having a little bit of fluid and a little bite of something to eat to make sure they're not hypoglycemic at the same time. And if they're really markedly tachycardic, then that's probably more of a sign of dehydration or exhaustion or something along those lines. Because again, there's nothing specific about that for acute mountain sickness, the vital signs. Now, once we start getting into HAPE and HACE, then those definitely factor in. right? So when we look at the criteria for pulmonary edema, you have the 2 signs and 2 symptoms, and one of those is tachycardia. So that's going to be, tachycardia out of what you'd expect for the fitness of that service member working at that altitude. And the tachypnea. So right at altitude, we're all breathing fast. That's normal adaptation. In fact, we want to do that. But if you're breathing, 15 times a minute more than I am, then there's something going on with your pulmonary system that's different than mine. So when we're looking at HAPE and HACE, I think those vital signs of the air after that 10-minute stop are going to be really useful. And that's really, really useful when you're looking at HAPE, right? Because if I'm in the mountains, you're in the mountains, we're walking around, we'll feel short of breath, right? Yep. That's normal. But when we sit down and stop, that should start to markedly decrease. So if we take a 10-minute break and you're still feeling really short of breath and you're still really tachypnic and really tachycardic, then that's really saying you have HAPE. So the vital signs are much more important for the high-altitude pulmonary edema. Mm-hmm. Now, with the high-altitude cerebral edema, that really just comes down to a couple of things. So ataxia is going to be the biggest thing that you're going to see. Somebody starting to get ataxia at altitude is going to be a very high likelihood that it's high-altitude cerebral edema. Now, there's, obviously there's some other things that could cause that. If they're breathing carbon monoxide in and they get up in the morning and they're, a little bit ataxic. Basically, anything that hit the brainstem can cause the ataxia. But if we're at 14,000 feet or 12,000 feet and somebody starts getting ataxic with a bad headache and they've had some AMS, then that really says this is HACE and we need to treat it that way. With HACE, you can have no AMS whatsoever. Most people that develop HACE have AMS that's been worsening, but there's the occasional person that won't have any complaints of any of the AMS symptoms and all of a sudden starts getting ataxic and then an hour later is in a coma. Rare, but it can happen, and that's why there is those 2 criteria for diagnosing it.
Yeah. I could definitely see somebody having, for example, the bad headache, and they just suck it up and they keep going without really understanding that, like, this could be an actual concern that you need to bring up, before target.
Yeah, and this is also the thing that as the medical provider, that you should be keeping an eye out for, right? If you're on an operation doing something and somebody starts getting ataxic, right? The 3 big things that we're worried about there, well, altitude, obviously high-altitude cerebral edema, hypothermia, and hyperthermia, heat stroke, right? All those things hit the brainstem first, the cerebellum first. So you start seeing somebody getting ataxic, then you really got to start worrying that something bad is going on. So the medical provider, that's the other thing you want to look out for. Yeah.
Now, when we were talking about pulmonary edema, one of those signs, you start hearing the crackles, like you mentioned before, the vessels, they dilate, they start leaking fluid, you start to get crackles. And obviously there's a giant spectrum of crackle in the lungs. And I would say we're pretty notoriously not great at picking out subtle signs in the field with our stethoscope. Do you think on a mission like this, an operation, a high altitude mission like this, it's worth, the risk is worth it to bring something like an ultrasound or?
So the ultrasound can help you, but honestly, I don't think you need it.
Okay.
Right. So the criteria, you can see the criteria, there are 2 symptoms and 2 signs. And a lot of times you may not see, you may not hear any lung findings, particularly early on with the HAPE. You're going to see the decreased exercise tolerance. That's going to be one of the biggest things early on. And then the dyspnea at rest, and then the tachycardia, the tachypnea, those kind of things. Ultrasound obviously is great for showing fluid in the lung. And you can use it to look for comet tail artifacts to show you that there's increased fluid in the lungs. And the more of those you see, the more fluid that's in there. So it's useful, but I wouldn't bring it for worried about HAPE. Obviously, I'm going to bring it for trauma and all those other kind of things. If I wasn't going to bring it for something else, I wouldn't bring it specifically just for this. Although now that you can, bring it the size of your cell phone, maybe that's getting a little bit more of a moot point.
Yeah.
Let's see. So we were talking about the HAPE and then the HACE. So there's, I think as you go through this, there's really good approaches to, to assessing a patient, and definitely want to reinforce the idea that if you have HAPE, you can concomitantly have HACE and vice versa. But certainly HAPE is probably going to increase your risk of HACE, right? Because you're increasing your thoracic pressure and you're decreasing oxygenation. So both of those are going to increase your risk. So that's what, when you go through the flow sheet, basically reminds you to evaluate, if somebody has HAPE, evaluate them for HACE also, and vice versa, because the treatments are going to be a little bit different between the two.
Yeah, absolutely. So obviously you have, skill weighs nothing. Understanding what to look for, definitely going to be your first tools there. Other than your stethoscope, what I've heard is, essentially, use a pulse ox, okay, get an assessment, and then take a pulse ox and go around the other people who doesn't seem to be affecting, just because as you go up, everybody's pulse ox is going to come down, just to see if we have an outlier with this guy.
Yeah, exactly. Now, honestly, I don't necessarily always bring a stethoscope, right? Because I can hear as well with my ears I can with the stethoscope. Okay. So that may not necessarily. I know it's kind of on the basic PFC list. You have a stethoscope, but if you don't, that's not the worst thing in the world. So the pulse ox, when everybody goes to altitude, everybody does the pulse ox challenge, right? Everybody's putting it on to see how they compare to everybody else. But if somebody is like 10 or more points below kind of what the average of the other party is, then that's concerning, right? There's going to be a little bit of variation, a couple points. But you start going 10 points lower and even more than that, the further you are from the baseline, the more I'm worried about HAPE. And that can be an early sign of it. One of the other things you can see with it is if you put the pulse ox on, you have people start walking or doing some exercise. If they desaturate with it, that's kind of even a little bit more concerning, because now they're reperfusing some of that lung that's hypoxic.
Okay. Do you think the end tidal CO2 would also be helpful?
It's not going to be as useful because you're hyperventilating already. So it's going to be low. You know what? If somebody's about to crump and their CO2 is coming up, maybe it's useful, but it won't be as useful as just the discrepancy in the oxygenation. In this case.
Okay. What else we got?
So there's some talk. There's talk about using the portable hyperbaric chambers, right? So there's a number of those out there. Not to endorse anyone. So the big three are the Gamal bag, the portable altitude chamber, the PAC, and the Certec bag, which is a European one. They're basically all the same. You put somebody in it, you pump it up, and it has the effect of dropping them several thousand feet. The higher you are, the more it drops them. So that's to use to try and stabilize somebody until you can get them down. When we're training with these, we'll use them at sea level here at JBLM, and we can take somebody from 200 feet above sea level and drop them down to minus 3,500 feet.
Ooh. Okay.
So that's at sea level. And the higher you are, the more it's going to go. Like if you're at 14,000 feet, it'll drop you down about 7,000 feet effective.
Okay.
So they're very useful for stabilizing somebody. The issues are obviously once somebody is zipped in there, it's very hard to do anything else to them. And they weigh about 15 pounds and they're fairly bulky. So that's the downside. That's kind of a mission consideration. Is that worth bringing because of the risk of you getting stuck and so forth?
Yeah, absolutely. I would imagine not for like a normal patrol, but if you're going to be hanging out there for a while, it's definitely, I would imagine it'd be a lot more worth it.
Yeah, exactly. Yeah, if you're going to be up high for a long period of time, then I think that's helpful. Some of the
so other than I guess assessments, because I think they're fairly basic and they don't require a lot as far as tools. Most of it is visual and what you can sense with your hands. What about things like treatments? Obviously, you know about pre-treating, right? Before you go, but some of that requires knowledge that you're going to those places, for a few days,
Yeah, and the kind of pre-mission planning discussion in the CPG kind of goes over a bunch of that. But certainly, even if so, the biggest drug out there for prophylaxis against AMS is acetazolamide, and that's talked about in depth there, and that's used worldwide. It's the number one drug, and it helps your body to acclimatize. So that's what's great about it. You need about 8 hours after the first dose to start getting a reasonable effect from it. So the good news is, even if you suddenly have to get thrust to a high altitude, even if you can start it 8 hours ahead of time, you're still going to get some benefit from it. And certainly a number of people are familiar with the pharmacologic rapid ascent protocols that have been used in the military for a little while. This goes over those again, and it bases it on how high you're going to go. So these are all rapid ascents, over 2,500 meters, more than 500 meters a night after that. And it'll break it down for you, is just acetazolamide enough, or we suddenly have to go up to 14,000 feet when we're unacclimatized, right? In that case, so 4,500 meters. So in that case, probably want to use acetazolamide and dexamethasone. And that's all covered in the pre-mission planning and the rapid ascent protocols.
Okay. So, even after we've done our protocols, right, we've pushed out, we're still getting symptoms. Is it okay to continue dosing?
It is with the acetazolamide. And in fact, the prophylaxis dose, the treatment dose are different. So certainly if you're getting symptom, you get AMS, then basically essentially what you do is you'll just double your acetazolamide dose. Now the dexamethasone gets a lot trickier with it. Taking a couple doses of Dex, if you have severe AMS, can make you feel really good and get rid of all those symptoms. But because it's also masking, and as soon as somebody comes off of it, they can rapidly crash and burn for that. That's why we say if you're using dexamethasone for symptoms or treatment of AMS, they definitely should not be ascending until they've been off the Dex for 48 hours, right? And that's giving a conservative time frame in between, because the idea is if we send that person up high, they are really at increased risk of developing HACE or severe illness, because we're basically masking their symptoms with Dex.
Okay. So as far as pharmacologic treatments for HAPE, how fast should they be improving? So
HAPE, if you can get them down and put them on oxygen, they'll improve, rapidly over the course of 12 hours to a day. And in fact, they could probably get to the point where they're off oxygen in just a day or two. On the civilian side, in fact, you'll see what happens at a lot of Colorado ski areas is somebody gets HAPE, it's relatively mild. They get sent back to their hotel room on an oxygen concentrator, and they're there for a couple days till they don't need any more. They can get up and walk around without any oxygen. And once you're asymptomatic off oxygen from HAPE, then you can go back up 3 days later.
Okay.
So it responds very quickly if you can get them down and put them on oxygen. Now, if you're stuck with them at altitude, that's going to prolong how long it's going to take them to get better. And if you don't have oxygen, right, they may not get better with just the pharmacologic therapy.
Okay. Could they at least stabilize?
That's one of those, depends on how sick they are, and just can't say, right? That's our hope. Our hope is to stabilize them and then bring them down as much as we can. Because even a couple hundred meters might make a difference for them. But if you're really truly stuck with them, then that's why you use the pharmacologic therapy, the oxygen if you have it, the portable hyperbaric chamber if you have it, and you stabilize them as much as you can, and then try getting them down so they can recover quickly and then go back up.
Yeah, absolutely. I mean, I think it makes sense here. If you're bringing a hyperbaric chamber, like, why did you not bring oxygen? Like, it's not that much heavier now.
It's not, but as you know, it's the amount of one of the reasons that we can't treat this very effectively in the field, and you can do it at a Colorado skier, is because you have an oxygen concentrator.
Yep.
Right. You think about how quickly you're going to burn through your oxygen supply, even using 2 to 4 liters a minute. Where if you need it for 12, 24 hours, that's going to be hard. But I agree with you. If you're bringing the portable hyperbaric chamber, you should have at least a little bottle of O2 to try and stabilize them long enough to get them down.
Or even the generator. The batteries aren't amazing, but I mean you'll get at least a few hours out of a battery.
Yep. Yeah. Exactly.
So going on to HACE. Okay, we've skipped over AMS because he didn't bother saying anything. Now he's kind of staggering around. I have suspicion he might be having HACE. Okay, essentially same treatments.
So this one's going to be different, right? So there's no, for HACE, if there's no concomitant HAPE, then there's no utility in nifedipine or the phosphodiesterase inhibitors, right? They don't help it at all. So here, our number one treatment is going to be dexamethasone. Does a number of things, but that's the number one treatment.
Okay.
And trying to get them down before they become comatose and have to be carried down.
Okay.
So, first step's going to be the dexamethasone. And if somebody's got HACE, I'm going to start them on it. They start getting ataxic, I'm going to start them on it so I can try and get them down. And if we're stuck with them at altitude, even more so, and keep dosing that and putting them in and out of the hyperbaric chamber. So I know the question that you want to ask me is that, well, if they get really sick, how about hypertonic saline?
Yes, I've been waiting.
And so nobody's published any use of it for altitude. Theoretically, it would probably help. And talking to one of the altitude experts, he's actually put it into the protocols for their EMS at high altitude. So if somebody's in extremis, then certainly I would try it. We know it works for a whole host of different vasogenic edemas and high altitude cerebral edemas and other vasogenic edema. So I think if somebody's in extremis, they're comatose, then by all means, it's worth trying. Now, if they're just got a bad headache and they're a little bit ataxic, I wouldn't give it at that point.
Right.
And I would certainly only be using hypertonic saline. I'd probably steer away from mannitol. I know that's probably not, you're probably not going to ask that question, but at altitude, we expect that most people are volume down just because acclimatization brings you volume down. So the mannitol is going to make you even more volume down, whereas hypertonic saline is not as much of a risk.
I mean, one, he's exercising. He's taking a diuretic with acetazolamide. I'm not sure the diuretic effects of dexamethasone, but taking a steroid can seem like it can dry you out. Probably not drinking lots of water to begin with, because he doesn't have lots of water. And now, you want to shrink his brain with mannitol.
Probably not. And just if you're normally acclimatizing to altitude for those first couple months, you're increasing your urine output and you're dropping your plasma volume significantly. And that's just normal, right, for everybody. And it takes several months of altitude for that to get back to normal. So we expect people to be 10 to 15% down in their volume status just from acclimatization, for those first couple months there. So everything's making you dehydrate and volume down.
Right. Now I understand, with HACE, he's getting effects of the brain. Now are the things we were worried about with dexamethasone kind of starts going out of the window because now his brain is starting to swell, right?
Once you get HACE, then we're going to start big dose of dex, and we're going to keep giving you, so that's why we say the 8 milligrams. Honestly, I just tell everybody it kind of depends on the what you have. Like if you have the 10 milligram IV dosage, I just give them the whole 10. But to make it easy, we say 8 milligrams up front and then 4 milligrams every 6 hours. And you keep them on that until you get them down, and they're improving. Okay.
What is the risk or what is the downside of using dexamethasone?
A number of things. So it's certainly, it's going to increase your sugar. prolonged use, it makes you psychotic. It starts causing steroids at altitude start causing gastric erosions and gastric very quickly. But here we have somebody that has haste, something's going to kill them. So yes. I'm not so worried about that. Adrenal suppression, that happens after about a week. Again, at this point, we're not using it for prophylaxis where we're worried about the side effects. This is treatment. So I'm going to keep that treatment going until we can get them down.
Okay. But, would it be safe to say not just hypertonic saline, but any of the other things that we would use for a TBI could apply?
Well, you really kind of got to depend on which thing, you're...
Right. Well, elevation, right? You're raising the head 30 degrees.
So the 30%, definitely. There's still some folks out there that are using loop diuretics for TBI. Kind of gone out of favor, but so I would definitely not use that. We've already talked about mannitol. If you need to intubate somebody, certainly intubate them and then, mildly hyperventilate them. That's going to get a little bit kind of more tricky as to where you do it, because you think about all the rest of us, we're already hyperventilating there. But so those standard things, by all means, definitely the 30 degrees elevation of the head.
Okay. Now, would they be alkalotic now that they've been hyperventilating? Are they generally the patients generally alkalotic, or are they still on the acidotic side?
So typically you're going to, as they go through the process of acclimatizing, right? So you're developing a respiratory alkalosis. Yep. So that's normal, but fairly rapidly your body starts to secrete that bicarbonate to bring that back to normal. So really your pH should be in the normal range or close to the normal range with the acclimatization, right? It's not uncompensated when you go to altitude. If it was uncompensated, we wouldn't be able to keep hyperventilating and wouldn't be able to adapt to the altitude. So if they're now, if you actually did have some way that you could check a blood gas on somebody, then you would adjust them towards normal pH, because with normal acclimatization, you should be normalizing, right? You'll match your respiratory alkalosis as reasonably close with a metabolic acidosis.
Okay. Maybe a dumb question, but one of the other options for TBI is sodium bicarb, using 1 or 2 ampules. So that's roughly 100 cc's of sodium bicarbonate.
Again, nobody's ever looked at that or used it. I would probably keep that as my 4th line after the hypertonic saline if somebody was, comatose and in extremis.
Okay. Because, we're going to be limited on how much hypertonic somebody's going to be bringing. I don't imagine you're bringing 3-4 vials of it. You're probably bringing 1, and that's in your emergency box.
Yeah, no, and we're actually really starting to kind of go further and further down the rabbit hole here.
Yeah.
Right. Hopefully we've picked up the haste much earlier. But I can see some situations like, somebody has, somebody brings down a team member to the first medical provider they have, and they're already comatose and in extremis. So that's when you start thinking maybe these 3rd or 4th line approaches.
I'm not trying to suggest like we jump into it, because I know that's what medics love doing. But if the idea, especially it's the podcast, a prolonged field care podcast, so everything has gone bad. You can't come down. He was, 6 hours ago complaining of a headache and stumbling around. Now he's even worse. I've been doing the DEX. It doesn't seem to be working.
That's when I'd give the hypotonic saline, and then if you run out of that, then I'd maybe think about the bicarb.
Yeah.
And then protecting the airway at the appropriate point in there as you need to.
Yeah, absolutely. So those are essentially all the really horrible things that can go wrong, right? Mountain sickness, not too bad. They complain, give them some Tylenol for their headache, and maybe slow down and take a little more frequent breaks.
Yeah,
hopefully you acclimatize first.
Yeah, give them some Zofran for their nausea, right? So AMS is really symptomatic treatment, and then if you want to help to acclimatize or get better quicker, you give them the acetazolamide.
Yeah.
Probably should bring up the one thing that's usually a question with acetazolamide is, does it affect exercise capacity?
Mm-hmm.
So that's one of the debates that why a lot of operators don't want to take it. Because certainly at sea level, if you just go ahead and take Dex for no good reason whatsoever, it will decrease your exercise capacity a little bit. But at altitude, that really doesn't seem to be that much of an issue. And the best study to date on it through NATIC says that for the most part, it's not going to affect exercise capacity at altitude. Because all the other stuff that we have going on at altitude is kind of affecting it a little bit also. So at altitude, it's not really an issue. For the vast majority of people, there's always going to be exceptions.
Yes, of course. Yeah, there's always going to be the guy that blames, that's why I can't keep up.
Yeah.
But things obviously, they start getting worse. We have HAPE, we went through, HACE, we also went through. Obviously, it's better to get ahead of things before they start getting bad. So, we already mentioned, acetazolamide, potentially Dex if you have to rapid ascend, at least 8 hours notice. You can start that and actually have some beneficial effects. What other things can I do with the anticipation of, hey, I'm going to have to operate in this environment?
Well, so there's discussion in there about pre-exposure prophylaxis, or intermittent hypoxic exposure. So basically putting yourself in hypoxic conditions for a number of days ahead of time. And again, NATIC's done a bunch of really good studies on that. If they put you in a chamber, bring you up to high elevation for 4 hours, for 5 days, for a couple weeks, if they suddenly then thrust you up to high elevation, you tend not to get sick and you tend to do very well. All of those take some time. And for the most part, it looks like it really needs to be hypobaric hypoxia. So actually have to be at altitude. Mm-hmm. So you hear people talking about, and some elite climbers and so forth, talking about sleeping in the oxygen tents at sea level. The literature right now on that is really only anecdotal. There's not great literature saying that you can do that. Now, the issue for operators is going to be, if I suddenly have a short notice mission, am I going to have 2 or 3 weeks to do intermittent hypoxic exposure before I go there? Well,
probably not.
But whatever, the more you can get, the better it's going to be. The studies say it needs to be, a certain amount of hypoxic exposure over a couple of weeks, but, if you can get a couple days, it's not going to hurt.
Okay. Is there anything I can do at sea level that doesn't involve a hyperbaric chamber?
No. Just don't put the Bane mask doesn't work.
No?
Just call it out. The Bane mask is of no use.
Okay. Obviously, just good nutrition, hydration.
Yep, and there's there's some interesting stuff with iron infusions that NATIC's looking at. Don't know if it's going to be as good as it might be suggested or not, but certainly make sure that somebody's iron status is normal, right? We know that a lot of ultra elite athletes and young females have low iron stores, so I would just make sure that people have good nutrition, like you're saying, and part of that would be making sure that you're maybe taking a multivitamin with iron every day to go up. Okay,
perfect. Is there anything else any other specific changes that happened with this new CPG?
I think those were the biggest ones. The greatest thing that's going to come out of this, obviously, is that there's the medic encounter form, or the medical encounter form that can be filled out and sent back to the JTS to start recording data, and that's going to be really useful for us, to figure out how much of an issue altitude illness is for the military, how are we doing at treating it, and then maybe even, does it turn out that some things are working better than we expected or worse than we expected compared to the civilian side. So certainly anybody that has service members at altitude with anything, please fill that out and get it back to the Joint Trauma System.
Perfect. Hey, thank you, Ian. I really appreciate it.
Yeah, thanks, Dennis. Great being on again.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.